and the identification of red flags noted by physical therapy contribute to the diagnosis of systemic illness. This case report outlines the treatment of a 39-year-old woman with undiagnosed multiple sclerosis being treated for left knee internal derangement. Comorbidities included Behçet's disease, type 2 diabetes, and complex regional pain syndrome after an unrelated right knee surgery. She had been experiencing concerning symptoms including heat intolerance, migraines, narrowing of peripheral vision, excessive fatigue, excessive sweating after eating, facial numbness, and an uncontrollable tremor of the right leg. Prior to her evaluation, this patient had sought medical care for these symptoms with her primary care physician, referring orthopedic physician, and a pain management specialist. Each conversation with the physician led to discussions of pain management where the symptoms were dismissed as an effort to obtain prescription opioids. During the initial evaluation, the patient reported multiple falls per day and significant pain due to the complex regional pain diagnosis, but all red flag symptoms were intentionally withheld by the patient during the systems review out of fear of referral and eventual dismissal by pain management. The initial examination revealed global lower extremity pain and weakness, 85 degrees of knee flexion, and lacking 10 degrees of knee extension. The patient completed functional outcome measures, including a lower extremity functional scale with a score of 38 out of 80, a numeric pain rating scale with a score of 4 out of 10, and a body pain diagram pictured in the poster below. The patient performed roughly 4 weeks of strengthening without signs of concerning symptoms. During this time, she participated in mobility exercises consisting of heel slides, prone knee extension, and prone quad stretching. Lower extremity strengthening exercises were performed, including quad setting, clamshells, hip abduction, straight leg raises, bridges, and abdominal bracing. Also included were manual therapy consisting of soft tissue massage, grade 1 and 2 joint mobilizations, and gentle passive range of motion, and game-ready cryo-cuff for pain management. Her strength in the various exercises gradually progressed, but no change was seen in her frequency of falling. Range of motion of the affected knee increased to 115 degrees of flexion, and extension was measured at lacking 1 degree. Manual muscle test scores were roughly unchanged for either extremity. Reevaluation at 4 weeks showed a lower extremity functional score of 24.5, increase in frequency of falls, and progression of pain locations on the pain body diagram. At this time, the patient was referred to her primary care physician due to seemingly progressive nature of her condition. The referral once again led to pain management, which caused frustration and mistrust from the patient. Upon returning to physical therapy, significant changes to the plan of care were made to ensure patient safety and prevent exacerbation of symptoms. Such alterations included decreasing exercise intensity, educating the patient on energy conservation techniques, and potentially lowering room temperature to ensure the patient wasn't overheating. The patient fell at home during week 6, which resulted in a right ankle fracture. Exercises were again modified due to increased pain levels and non-weight bearing status per the treating physician. Reevaluation at week 8 further progression of symptoms with the body pain diagram showing nearly the entire body as being painful. No change was seen in lower extremity functional scale scores, and the numeric pain rating of 8 out of 10 was seen. The patient mentioned her concerning symptoms to the therapist during week 8 of therapy after establishing trust and building rapport. She then revealed that she had previously had an MRI on her brain that revealed no signs of neurologic disease. The patient was instructed to make an appointment with a neurologist, but was unable to get an appointment for more than 6 months. Luckily, she had an upcoming appointment with her endocrinologist for her Behçet's disease. The physician was provided with an elaborate summary of the patient's symptoms, details of physical examination, recent regression, and brief medical history. The following week, she was diagnosed with multiple sclerosis and instructed to be discharged from therapy by the treating physician. This case study clearly emphasizes the negative effects of an undiagnosed autoimmune disorder on an individual's independence, safety, and overall quality of life. Strength and mobility gains were made in nearly every category measured, which could have potentially helped to prevent even further deterioration when the patient was not in an acute exacerbation. Research has frequently shown that physical therapy can help slow disease progression and maintain levels of independence in multiple sclerosis patients that are not in currently in an acute exacerbation. However, the intolerance to exercise and rising safety concerns likely places her in such an exacerbation throughout much of her therapy, leading to eventual discharge. This allowed the patient to seek the medical care she needed without further risk of falling or further exacerbating her condition as was currently being seen. This patient helps to solidify just how critical it is for physical therapists to perform a thorough screening for red and yellow flags during the initial evaluation and throughout the course of treatment. Certain autoimmune diagnoses, such as multiple sclerosis, are achieved by exclusion of other disease and may take years to achieve an actual diagnosis. Had these symptoms continued to go unnoticed, serious harm could have potentially come to the patient. Familiarizing oneself with the signs and symptoms of common diseases, autoimmune or otherwise, could help the clinician to quickly recognize that something is amiss. Upon recognition of any red flag that seems to signify a disease or disorder outside of the scope of our practice, the therapist must make a referral back to the appropriate physician to allow the patient to receive the care that they need.